Thanks so much. Clearly, when you're all wearing lycra, I look rather like people who are faster than me. I tended to be looking at your backside a bit much, I think, Sean. But thank you so much for inviting me to be part of this meeting. I'm stoked to be here. I'm stoked to share with you something that I think is truly exciting. I live and work on the Adelaide Plains. I have the immense privilege of scootering through our parklands of River Red Gums, the land of the Kaurna people, and I'm really grateful to have this opportunity to keep the idea of meetings and discussing important issues and growing wisdom on the land of the Kulin Nations. I pay my respect to the First Nations here and all across Australia and the Torres Strait. I also think it's really important for you to know what's in it for me. I'm in the knowledge generation game, so much of what I do now is at this sort of how does the brain work end of things, and then how do we get that across to the people who will really benefit from understanding that. And when you're in the knowledge generation game, trying to understand how we think, you immediately recognise that the brain cannot ignore data. It cannot ignore anything. So I'd like you to do this little exercise just to prove that. I'd just like you to write down in your head, or on a piece of paper if you like, the word pain. Easy task. Can you raise your hand if you spelt that word P-A-I-N? I think that's pretty much everyone. Raise your hand if you spelled it P-A-N-E. No one. Very legitimate, equally valid response to that question, and I imagine that none of you even thought, oh, which one should I select here? And that reality where I'm talking about pain, with the pains up on the screen, these are all things that your brain can't ignore in predicting what's the most appropriate outcome here, which is why you should look at my disclosures, because there's stuff in it for me. So I'm supported to be here by Gallagher Bassett. Stayed in the nice hotel last night. That was lovely. Thank you, Gallagher Bassett. There are other influences on how my brain works. For example, you can see there that I have slept with the devil, that I've received money from workers' comp boards, that I get royalties for the books that I've written. And in fact, if all of you bought all of my books, that would just be a great outcome. And I'd be able to go to dinner tonight and pay for at least half of it on the proceeds of that. I think this is actually important. I think often when people put up their disclosures, they say, and these are my disclosures. And you don't get an opportunity to ask that question, what's in it for him? Okay. So I'm not going to tell you anything very surprising. I don't think I can turn my screen off, but a fundamental aspect of how the brain works is that I don't want you to divide your attention between me and the screen. So I always like to be able to turn the screen off. So I can't, but I'll give you a really boring screen while I tell you a story. So about 3 years ago, I was walking my dog, Tessa. Tessa is embarrassingly a spoodle. But wasn't my choice, but I lost 3-1 on the choice of dog. But she's a beautiful dog, and I was walking down the street, and she goes nuts as she recognises our car, and our car drove past. Well, it was being driven by the beautiful Anna, but the car went past, and Tessa decided she'd keep up with the car. And me, in my wisdom, thought, I'm going to keep up with Tessa. I know, mid-40s, but I think I've still got it. And I was sprinting, and while I was sprinting, the leash was getting a bit slack. And I thought, how fast am I? 45 faster than the spoodle. And I started to have a go at Tessa. Come on, Tess. And I was so stoked with myself, and I got to the oval, and then I started to get a little bit of back pain. Moved around at the oval. By the time I got home, I had quite severe back pain. The next day I woke up and I had pain down my leg. It was brutal. It was brutal pain. It slowly resolved over the next week or so, and I was completely pain-free maybe 3 weeks later. In that journey for me, that I reflected upon later, it never occurred to me that I had done any sort of damage. And I think that reflects my training as a physiotherapist, my understanding of tissues, my understanding of mechanical loads during the task, and my appreciation for the beautiful impact of any inflammation on our ability to detect danger. So I knew the whole time, wow, this is a highly protective response. But then I reflect on what would have happened, I think, in the vast majority of people who had had that same experience. And if they were unable to go to work because of this brutal back pain the next day, they would probably go to a GP, and the GP would, according to guideline care, ask, have you got any leg pain? And that question and the response to that question could easily kick off a descending spiral and what I would describe the commencement of one of the tragic pathways. And I actually think highly resourced individuals will slip down that pathway with that mix of symptoms. And I think we need to change that reality. Clearly, persistent pain is a massive burden, and no one in this room would be that surprised by this. It's a global burden that's bigger than diabetes and cancer combined as far as years lived with disability and indirect costs. This is the Global Burden of Disease study. This happens every few years, published in an obscure magazine called The Lancet, and they look at a whole range of health conditions. And just to get your bearings here, that colour there is the big kahuna burden colour. The far left-hand part of the screen is what's happening in the world, and then Australia is 3 over. And then if we look closely there at the top 11, low back pain wins. Depression is probably not surprising, wins globally and in Australia. Neck pain is number 3 in Australia. Other musculoskeletal disorders, which include things like hip pain, knee pain, they rate fairly highly. Migraine, osteoarthritis, and the major burden of osteoarthritis is pain-related and knee replacement related. This won't surprise you, I imagine. I hope not. These are data you might be familiar with, that back pain is the most common reason people leave the workforce. People who leave the workforce with back pain, and this is persistent back pain, this is very seldom someone who's got an acute back injury through a catastrophic event. These are people who had a non-catastrophic event and their back pain never went away. And when they leave the workforce, they have about 60% of the wealth that people leaving the workforce for other reasons have, which is a massive burden in itself. And some really, I think, compelling data that are coming out of Chris Williams and Newcastle's group, looking at big data sets, looking at associations between persistent pain and subsequent diagnoses. And with odds ratios that are really intimidating, you increase the likelihood of getting subsequent depression, you double that. Suicide 1.5 times, stress, drug dependence, not just the opioids, but clearly the opioids are a massive problem, alcohol dependence, cancer, diabetes, and other obesity or metabolic diseases. Having persistent pain is not only in and of itself a massive issue, it is clearly an important step towards other massive issues that are really intimidating. So hopefully no one is that surprised by this idea that persisting pain is a massive problem. Part of that, I think, are clinical pathways that do not provide high-value care. And we've actually learnt a lot about what's a good way to treat someone with pain, not just back pain, although that is the big kahuna, but someone with pain. But you might be familiar with these sort of pathways. So pathway 1 I like to call the bolter. This involves the patient going to the GP. The patient has pain, so they might have back pain, shoulder pain, neck pain. Goes to the GP orders a scan, and that was a really interesting engagement here maybe from yesterday. And I related to that story that you recounted, Virginia, of the patient saying, yeah, but it really hurts. And the common response to that is, okay, well, maybe against guideline care, but it'll be reassuring. Or the clinician, I'm panicking as well. We get a scan, we will almost certainly detect abnormalities, or we will detect aspects of that scan that are described as abnormalities, and I think this is something we have to change. That normal adaptations to load will give you a change in the shape of your vertebra over years, which is great. They become stronger because ligament now turns into bone. Just think how remarkable that really is. Imagine if you had a car that when you load the tyres, they grow rubber. Wouldn't that be cool? Or as the petrol's getting more and more expensive, the car just slowly changes itself to a little bit of electric power. But this is biology. This is the irresistible force of biology. To be alive is to adapt. Yet we describe these adaptations on scans as degeneration, as abnormalities, and this is a very intimidating message to hear when you've got the pain and then you've got the scan and you put them together. Comes back to the GP, and the GP may very well refer to what I think is a classic habit that we now have in our language of going to the specialist. Isn't that intriguing? What I would like to meet is a specialist in the ability to best judge how you're meant to walk downstairs with this spacing. Does anyone else realise this coming down the front? Like when you sit down the front and you don't know whether to go one step for each or two. You know, does anyone else have that problem? And if you go 2-2-1, 2-2-1, you think people are looking at me. And if you just go one, you think this is a long way to go. And if you go two, you think it looks like I'm in stilettos. I want to meet a specialist who will just coach me on that, whatever these specialists are. The specialist will probably rescan or do a different kind of scan and will therefore almost certainly identify potential surgical targets, which may very well lead to surgery. Surgery is often a low-value intervention for these things. Sometimes it's an excellent intervention when it's indicated, but most surgeries, certainly for back and knees, are probably not indicated. And then the patient heads back to the GP, and then I would say they're on this maintenance therapy, secondary diagnosis. Well, I've got to see this person. Oh, this person's great with backs. Go and see that. This other pathway. I would describe that as the bolter. What about the wait in fear pathway? And this is one of the pathways we have in Adelaide. We've done a lot of work here looking at the pathway into the spinal assessment clinic at the Royal Adelaide Hospital. Goes to the GP scans, rightly or wrongly, and refers to the spinal assessment clinic. High quality physiotherapy-driven assessment, most of which will say, there's nothing urgent here, we'll put you on the waiting list to see the specialist. Goes back to the GP and then sits in this descending spiral of waiting. We looked at the utility of predictive tools in that pathway to see which tools predict good outcomes better than others. And one of the most disappointing aspects of that study was that there really are no good outcomes. 85% of that cohort waits for their specialist appointment. And during that time, they might sit at home. They literally sit at home. Or they might invest in what I would say that maintenance therapy. We'll keep you going, we'll give you some pain relief through whatever system. What about the smiling assassin pathway? This one, I think, everything's going smoothly. The patient sees a great GP who is able to reassure them well and say, look, guideline care shows no scanning. Wherever Stephen, are you not here? Anyway, shows no scanning. Excellent, goes to the physio, good current thinking physio, except they're very well trained in detecting pathologies in the musculoskeletal system, and they will detect pathologies. In fact, there is an increasing body of one school of physiotherapy that doesn't need to confine itself to finding pathologies in the back for back pain or the knee for knee pain. They just need to find a musculoskeletal pathology somewhere and then correct that. And the pathological targets are treated. and we're back in this maintenance therapy, secondary diagnoses. There's one physiotherapy teacher who comes to Australia every now and then with a certain pathological model of thoracic spine and neck pain. And when that person leaves, I will get a dozen, 20 phone calls from patients around Australia saying, my pain's come back, therefore I know my rib is out. Are you able to put it back in? Because the only person I know who can put it back in has gone back to their country. These are bad situations. What about the one that got away? So yeah, great physio, does a lot of good education, reassurance, screens for the wrong things, they're not there, gradual loading, and then the patient flares up. Then the patient might be progressing slower than they or their physio expected, and that's a trigger back to one of the tragic pathways. I imagine you will recognise this, and I imagine that some of you could replace the patient directing that shift or the physio directing that shift to you directing that shift. Wow, that's a big flare-up. And then the model we've got suggests let's go back and start again. And we're back on one of the tragic pathways. There have been massive progresses in science. Major scientific progress has identified the optimal pathways for care with musculoskeletal pain, or in fact other pain presentations. We now have methods of treating that are clearly better. So this might be generous to say we know how best to prevent and treat persistent pain. But we certainly know of the pathways available, we know which ones are the best. But actually we aren't doing it. I fully appreciate this idea of the guidelines, but most clinicians don't implement guideline care. They're aware of the guidelines and they don't do it. This is a real challenge that we face. But I think one of the reasons for this is that the best treatment and prevention strategies actually make no sense to most people when it comes to pain. The best treatment and prevention strategies make no sense to most people when it comes to pain. Why is that? Well, because we've got this model of pain that René Descartes proposed in 1654 that's been fully refuted, but it drives care. It still drives care. Pain is in the tissues because of some sort of structural pathology and is transmitted to the brain. That's wrong. I feel sufficiently strongly about that to have taught my children a song when they were young, and it goes like this. René Descartes was very, very smart, which is why we sing this song. But I must impart he was a jolly old fart. And as it turns out, he was wrong. And once when my son, Lord Adorable Squeaky Pants, was about 2, he managed to fart on cue. René Descartes was very, very smart, which is why we sing this song. But I must impart he was a jolly old fart. And you know those times when your children, if you've got a child, they do something that you're really impressed by, but you sort of don't want to encourage it? Have you had that experience? And I was in this internal dissonance of, that was amazing, great motor control. And physiotherapists, you think, well, that's very good. Eventually I just had to put my arm around him and say, oh, I love you, Henry, that was just outstanding work. Good on you, Gubs. René Descartes was very, very smart, but that model is wrong. Pain is about protection. It's never about informing you about the state of the tissues. Pain is something that should help us facilitate recovery. And unfortunately, that's not how it's perceived. This is a table out of one of the papers in The Lancet this year. Got a lot of attention around this call to action, got a lot of media attention as well. And the attention in the literature and in the popular media was all about saying doctors are mistreating pain and patients just need to exercise and get counselling. And this is what happens every couple of years in my field, maybe every 4 or 5 years. There'll be a high impact review and it will conclude exactly the same thing. And we start having a go at the few bad apples in the bucket, the doctors who are doing the wrong thing, or the patients who we think, come on, get on with it. But I think we're missing the point. I think one thing we're missing is that we don't have a few bad apples in the bucket, we had a bad bucket. and we need to do something about the bucket. And the other point is that exercise, graded activity and psychological intervention makes no sense for pain unless you understand pain. And the first line care, this is summarising guidelines around the world, first line care for back pain, and I would apply the same to every other musculoskeletal pain, is education. Education. Reassurance and education. Advice to be active. But the key is people need to understand why that's a sensible piece of advice. The doctor just saying, I think in Virginia, your words, no, it might have been Stephen, we know what we're doing, go away, is all very well if the patient can understand that you have any idea what you're talking about, because I have pain. I don't have a psychological problem. I've got a bodily problem, and we need to educate on that. This is an editorial that I wrote in the British Journal of Sports Medicine in response to those articles, an invited editorial, which also got a lot of attention, but this is really pushing my view, based on my interpretation of a very large body of data, that we need a revolution in how we understand pain and how we think it should be treated. We clearly have to educate patients, and I think we need to educate people before they're patients, so that they don't panic when their pain is very, very bad. And back pain can be brutal. We need to educate GPs, we need to educate physiotherapists, but I'm satisfied in 15 or 20 years of being involved in this that those three strategies are not enough. I think we have to educate everywhere. We have to get to psychologists. We have to help psychologists understand that a worsening in pain doesn't necessarily reflect better get back to the body person. We have to educate clubs. We do work with football clubs and surf lifesaving clubs to change the language around pain. Insurers, school, exercise physiologists, emergency department. The key is education. So how do we do it? And this is where the pain revolution comes in. We are taking a whole of community approach where we don't just want to get to the patient, we want to get to everyone involved in that patient's journey. As Sean has said, our vision is that all Australians will have access to the knowledge, skills and local support to prevent and overcome persistent pain. And what we want to do is embed the capacity locally, and I think this is quite important. That the common model, certainly in rural and regional Australia, is that the experts from the city come out for a day or two and then go back. We think it's not rocket science once you understand, and we want to embed that capacity in communities. We really want to target the grassroots and get the general public to turn up at the GP and direct care, because guidelines are not changing care. We want patients to ask different questions. We want to shift the model of care when it comes to pain from one of endless pathology detection and correction to one that really respects a very large body of evidence to say you really can't stop the irresistible force of healing. It is an irresistible force of healing, and let's respect that and get out of the way and facilitate recovery and reassure and give people the confidence that, yeah, this is horrible and your system is already changing. Your system, Jennifer, is adapting. That's our conversation this morning. You are adapting. So we're going to regional and rural centres. We're looking at the entire network. The first thing we want to do there is identify a local pain educator. So that person becomes the local champion of educating their community. We train them extensively. We support them with an individual mentor and a network of local pain educators and mentors over the course of a 3-year training program, and we help them to target their community with outreach events aimed at the general public. Some of those this year are including a knitting club in Nowra, on the south coast of New South Wales, surf lifesaving clubs in Victoria, football club in Mount Gambier, schools, Lions Club, Rotary Club, trying to teach the general public a new conversation and a new sense of what is possible when it comes to pain. They also deliver health professional workshops, and we help them prepare that, coach them in how to do that, give them resources to do that over the second year of their 3-year program. In the third year, they agree to become a mentor for the next cohort. This is a sustainable, upscalable program. Each scholarship costs us about $12,500. So it's not a massive investment. We're currently evaluating. We're feeling excited, but the full data are not in. Sean spoke about the Pain Revolution Rural Outreach Tour and Cycling event, which is a truly transformative experience for everyone. It's a really exciting thing. This is a few stats from the 2018 Sydney to Albury Wodonga. So we ate 880 bananas. We delivered 10 free seminars or workshops. We had 13 people turn up to those things, about 450 health professionals, including GPs, which is always exciting, 850 general public. I did 36 media gigs during the week and rode 800 kilometres, so I think the media gigs were the more demanding, especially when New York wants to talk to you on New York time. That was disappointing. A reasonable social media following, and we raised enough money during that week to support 9 new LPEs. This is a truly collaborative event. This is next year's ride, as Sean mentioned, but it's not a ride in isolation. But what we want to do is create attention. We really want to say, isn't this a novel thing to do? A whole group of pain scientists and pain physicians and stakeholders riding their bikes for this issue. That there is the possibility of dealing with this better. As I said, it's truly collaborative, and I love the tagline of this conference. Is really suitable to that. We're partnering with associations that are involved. The Tasmanian government has got alongside and is funding a good number of LPEs themselves. Industry sponsors, AIA, UniSA and Gallagher Bassett, and we work together to do this. And I think cohesion is a really important aspect of this, because we're not going to be able to do it as single operators. This is the tagline, I think, of this meeting: collaborate, innovate, achieve. And I feel like that fits really well with the Pain Revolution. It's a truly innovative idea as applied to health, that we want a revolution in the general public to try to get the changes that our top-down attempts are not making happen. And I think you can all be a part of that. For information, painrevolution.org. If you want to be involved in any way, if your organisation is interested in sponsorship opportunities, we need money. It costs us $100,000 to put it on, the tour. So we need to raise that money before anyone comes along. Tame the Beast is an animation-based website for consumers, for patients. Sean mentioned a couple of YouTube clips. One of the most cringeful things about this was that I got a creative company for 3 days, and I said, I'm going to teach you as much as I can about pain, and then you go and create something. So we did that, and they came back with something they'd created, and they said, here's the narration for it. Can you do the narration? Our market research suggests that would be a good thing to do. Can you narrate it? So I narrated it without seeing it, and then when I eventually saw it, I was a cartoon Lorimer in the animation, which is a little bit disappointing because, you know, I've got no neck. Like, I literally have no neck. There's nothing connecting my head to my body, and my kids think it's just absolutely hilarious, so much so that my daughter was busted in class with her and her mates laughing at the Tame the Beast animation. Hopefully you will find it useful for your clients and possibly even for you. I have 40 seconds to go, but that's the end of my talk. Thank you again for having me.